Great. Thank you, Colleen. And thanks everyone for having us. We're really excited to be here. Colleen set the stage really well for what we're doing today. We're talking about the Futures Initiative and the revision to the Essential Public Health Services Framework and what it means for public health. She's already stated our objectives. We'll introduce the framework, talk about the process, the revisions that were made, and try to articulate the connection between the essential services and other frameworks like accreditation, like the Foundational Public Health Services. Just a little bit about PHNCI. We are a division of FAB, the Public Health Accreditation Board, and really work to drive change and improve health through innovation in governmental public health. We're trying to make innovation more than just a buzzword, to think about it as a way for health departments to really transform practice, whether in big ways or small. And we're really pleased to partner with the Beauvoir Foundation on this initiative. They are a foundation for health that invests in bold solutions to build healthier community. They were founded way back when with the thought about creating practical tools. And so they really strive to create practical tools for public health and everything that they do. Just to ground us all in the familiar, I always like to start by talking about the original 1994 10 Essential Public Health Services and remind us that they describe the public health system. It's not just limited to governmental public health. And I think sometimes people just tend to forget that because health departments do use the framework so much. It's organized around the three core functions: assessment, policy, and assurance. And it's widely used in academia with the Public Health Accreditation Board and other frameworks being based on it. There's been international application, the World Health Organization has a version, and subspecialties like environmental health, like maternal and child health, all use or tailor to their own needs the framework. So we know a lot has changed in public health, and this really just helps remind us of all that has changed. So I'm going to scroll through some slides to just show you some images. I think they'll all look familiar, so there's really no narrative needed. But when we think about the why did we think it was time to look at this? You know, what has happened really in the last 25 years? And of course, where we are today. So we really founded this initiative, excuse me, to look at bringing the 10 essential services in line with both current public health practice, but also with an eye toward what would be happening in the future. We wanted to engage the community to assess the state and use of the current framework, and we started that by doing an environmental scan, really to see the kind of depth and breadth to which the framework was already embedded in the field. And we sought to build a consensus. This was a consensus-based approach to update and then refresh the national framework really with the field, not for the field, not to the field, but we wanted to ask, is this something we ought to be doing? So we looked at it as kind of a crowdsourcing initiative. Again, it was a partnership between the Public Health National Center for Innovation and the Beauvoir Foundation in terms of leading the work. And we did have a task force of experts. I'll show you that list in just a moment. And again, the public health field being a key contributor. So this is a list of our task force members and liaisons. Many of these names may look familiar, or certainly the organizations. We really tried to get a cross-section of the field. So practitioners from state, local, health departments. We wanted the perspective of foundations, of national organizations, our federal partners, not just from CDC, but from SAMHSA, from HHS, from throughout the federal government. The American Medical Association, and some of these people also have a focus on public health equity in their work. So we really wanted that kind of breadth. Also, in terms of there were people here who were around 25 years ago, they might have been on the steering committee that helped to create the first framework. There are also people who are newer to the field and newer to public health, and we thought that spectrum of perspectives would be really useful in approaching this work. So what did we do? I already mentioned that we began with an environmental scan to understand the history and use that is available online if you'd like to read it. I think people forget, 25 years ago, this was born out of health reform in the Clinton administration to really articulate the difference between public health and healthcare, and has been used so widely since then. We had two phases of data collection, one being that initial feedback, and I'll talk about that in just a moment, where we said, should we do this? And the second was after the revisions, were existed and we had a draft, and then said, what do you think about this? We had guiding principles that we used as staff and as the task force, that the work be equity driven and that our approach itself be equity driven, that it be transparent. So we shared notes from all of the meetings. We tried to post everything online. And again, there's a final report coming that has all of the data we collected for those who are interested. We tried to be inclusive, again, getting diverse perspectives from not only the members of the task force, but also during vetting throughout the process, and to be data informed and evidence driven. We tried to be future oriented and not predict the future, but think about a framework that would serve us well for the next 25 years, as the first one did, and certainly to be relevant. This was our timeline. It was relatively quick. We started in spring 2019 and we launched in September of 2020. Hopefully many of you were able to attend our virtual launch event. The archive's available online. It was a lot of fun. And then you can see the work that took place in between, multiple iterations of the actual revisions, a vetting period that we kind of slowed down due to the pandemic to give the field more time to respond, but did have a lot of conversation about, should we pause the work completely? Should we stop? And the answer was no. It was important to keep going. It was important to get this right, in particular, when there's such a spotlight on public health, to have something that really represents what public health practice is today and in the future. And of course, all of the data analysis. We also did work with a communications firm to help make sure we kind of got the words right. This is a tool that's used by the field, it's used by academics, but it's used by communities, it's used to inform policymakers. And so we wanted to make sure, to the extent that we could, to avoid jargon and to use words that were resonating. So during both phases of data collection, we had great responses. During that initial phase, we had over 1,300. That was through town halls, webinars, in-person, virtual meetings. We had a survey, an online questionnaire. Basically, anyone who would talk to us, we would come to their meeting and do this live polling to feed into that kind of crowdsourcing. So we had over 1,300 people participate in that, which was just incredible. During the vetting of the draft, we had over 600 responses. And that was all done via survey, which we also thought was really great. Again, we slowed that down. We allowed it to be in the field for a month or two of extra time to try to allow practitioners extra time to contribute. And you can see here the cross-section, the types of people that really contributed during that vetting and gave us feedback on everything from high-level concepts to nitty-gritty, change this work. So during that initial data collection, one of the key questions we asked was, should we do this? We didn't want to assume. If the field would have said, no, it's a terrible idea, leave it alone, that would have, driven the project certainly into a different way, perhaps a stopping point. But by and large, over 80% said keep the framework, but make minor or major revisions to it. Very few said keep it as it is, throw it away, but don't create anything new, or throw it away and create something totally new from scratch. So we really took this to heart. We didn't ask what minor or major framework revisions would look like, but set about kind of using the data we collected to make those revisions. There were more questions in this initial data collection about what needed to change, what was missing. And of course, things like equity came up, clarify, essential service number 7 around the role of public health and healthcare together, and things along those lines. And some of the themes that came up during initial data collection. So to calibrate you here, the bigger the box, the more comments we received. And what's represented here is if we received more than 50 comments on something. So again, we have much more granular detailed data that we'll make available in our final report. But you can see here, as I just mentioned, equity really coming to the forefront by and large as something that was missing, something that needed to be included. And separate from that, although certainly related, social determinants of health, as well as collaboration, community engagement, again, kind of honing in on healthcare and what does that really mean, informatics, things that just weren't really around 25 years ago. And so you can see here, we really used this and the more detailed feedback as a guide when we started to get into the revisions. So I'll pause here and turn it over to Katie Sellers with the de Beaumont Foundation to walk us through the actual framework itself.
Great. Thank you so much, Jessica. And thanks to all of you for inviting us and having us on your webinar today. I'm really excited to be able to share some of this work with you. So here it is. This is the new revised 10 Essential Public Health Services Framework. And as you can see, one of the most exciting things about this is that it very literally centers equity in the center of the circle. We did that because the task force really truly believed that equity is the end goal of our work to improve health and achieve health equity. And they also felt that it was important to articulate that in words to the side of the circle. So the old graphic, really mostly you just saw the circle, and we are trying to present this as a square, as a rectangular graphic, so that you have the circle and you have a little bit of contextual information as well. And I just want to go through this statement because I think it's important, and the task force really thought very carefully about how to word this. So the purpose of the 10 Essential Public Health Services is to protect and promote the health of all people in all communities. The 10 Essential Public Health Services provide a framework for public health to protect and promote the health of all people in all communities. To achieve optimal health for all, the Essential Public Health Services actively promote policies, systems, and services that enable good health and seek to remove obstacles and systemic and structural barriers such as poverty, racism, gender discrimination, and other forms of oppression that have resulted in health inequities. Everyone should have a fair and just opportunity to achieve good health and well-being. So that kind of sets the tone for the whole framework. Now, if you'll go to the next slide, please. I'll talk to you a little bit about how the language changed in each of the services. I'll just start by saying, for the most part, service number 1 is the same service as it was in the original framework. So service number 1 is assess and monitor population health. If you think about it that way, it's very similar to what was in service number 1 in the old framework. But I'm going to take you through some of the changes we made that were very intentional ways of updating practice, catching up to current practice in public health, making sure that this service is done to promote equity, and making sure that it alludes to some of the new developments like new technology, a heavier emphasis on multi-sector partnerships, and a new way of thinking about and orientation toward the community. So in this particular service, you can see that in the beginning language at the top, assess and monitor population health status, factors that influence health and community needs and assets. That factors that influence health is new, and community needs and assets, that signaling of the importance of community assets is also new. In this item, as you look through the different bullets, you can get more of a flavor for what this is all about. I'll just highlight some of the language that's new, the particular emphasis on disproportionately affected populations. Also, in the second bullet, using data and information to determine the root causes of health disparities and inequities. There's also an emphasis on working with the community to understand health status, knowing that just collecting some numbers doesn't tell you everything you need to know about health status, but that working with the community to understand needs and assets, as I mentioned, key influences, and narrative as well. The next bullet has that emphasis on multi-sector partners again, and data sharing, which is a newer concept in the revised version. Utilizing innovative technologies, as I mentioned, as it applies to data collection and data sets. Also using various methods and new technology to interpret and communicate data to diverse audiences. There's also, in the second to last bullet, you'll see an emphasis on analyzing and using disaggregated data, for example, by race, to track issues and inform equitable action. So again, that emphasis on equity. And then finally, engaging community members as experts and key partners. Next slide, please. So essential public health service number 2 is investigate, diagnose, and address health problems and hazards affecting the population. This one stayed the same in a lot of ways, although you can see it talks about real-time data. It talks about modern technology. And then in the last 2 bullets, the second to last one emphasizes multi-sector collaboration and also references the root causes of health status, whether they be social, economic, or environmental. And then the final bullet, identifying, analyzing, and distributing information from new, big, and real-time data sources, again, reflects the new capabilities we have in terms of data. And when I say we, I mean we as a society, not always the health departments or the public health system more generally. And so that's really a signal that public health needs access to that and to be utilizing that. Next slide, please. Essential public health service number 3 is to communicate effectively to inform and educate people about health, factors that influence it, and how to improve it. So that factors that influence it is new again, with that emphasis on really understanding root causes and political determinants and social determinants, as well as biological determinants and genetic determinants. There's also in this number 3, you'll see another emphasis on multi-sector partners. There's an update in here with a reference to social media, other new media channels. There's a reference to culturally and linguistically appropriate services and communications. It also talks about risk communication. And you can see how a lot of what's in this service number 3, a lot of all 10, but particularly number 3, you can see how that might apply very directly to what's going on right now with the pandemic. There's also a new reference in here to two-way communication, and that was something that the task force thought was very important to add. Communication is not just pushing messages out, it's listening to those you're trying to reach. And then finally, I also want to just highlight in the last bullet, ensuring public health communications and education efforts are asset-based when appropriate and do not reinforce narratives that are damaging to disproportionately affected populations. So again, giving that signal that some of the work we've done in the past maybe was not optimal, and that as we look to the future, we really need to be thinking about our communications this way. Next slide, please. Essential Public Health Service number 4, strengthen, support, and mobilize communities and partnerships to improve health. This one used to just say something about mobilizing community partnerships. And you're probably sensing from some of my comments already that the whole orientation towards the community has really been updated and changed in this new version. Again, there's an emphasis on multi-sector, but there's talk about fostering and building genuine strengths-based relationships with a diverse group of partners that reflect the community and the population. And then there's the third bullet says authentically engaging with community members and organizations to develop public health solutions. This service used to talk about how the public health system was solving community health problems. And now it is much more actively engaged with the community to develop those public health solutions together. Next slide, please. Essential Public Health Service number 5, create, champion, and implement policies, plans, and laws that impact health. So this is the policy one, and you can see there's more detail in this. There's more emphasis on policy than there used to be. And there are specific call outs to things like examining and improving existing policies, plans, and laws to correct historical injustices. And it talks about using policy to make sure there's a fair and just opportunity for all. The fourth bullet is providing input into policies, plans, and laws to ensure that health impact is considered. So some of that health impact assessment work that's been developed more recently in the last 25 years. There's also a reference to continuously monitoring and developing policies, plans, and laws that improve public health and preparedness and strengthen community resilience. There was not nearly so much focus on preparedness and community resilience in the first version of these. Okay, moving to number 6. Essential public health service number 6 is to utilize legal and regulatory actions designed to improve and protect the public's health. And you'll see that this one is really about ensuring that applicable laws are equitably applied to protect the public's health. This is what used to be thought of as the enforcement item. Bullet number 2 is still all about enforcement and really talks about some of those long-standing public health efforts that absolutely still need to happen. Licensing and monitoring the quality of healthcare services is in here. Also reviewing drug, biologic, and medical device applications, licensing and credentialing the healthcare workforce. You'll see there are references to the healthcare workforce and the public health workforce later on. But this is the legal and regulatory actions, public health services. So the focus on the workforce here is really just limited to licensing and credentialing. And then also including health considerations in laws from other sectors, such as zoning. Again, that's a little bit of a health and all policies focus that has come into play more recently in public health in the last 25 years. Okay, number 7, essential public health service number 7 is to assure an effective system that enables equitable access to the individual services and care needed to be healthy. So this one in particular is really a key service to distinguish public health from healthcare. Not that they're completely separate, but that public health has a specific role in healthcare, which is not necessarily providing healthcare to the public. You'll see an emphasis on health and social services that support the whole person, including preventive services. There's also a new reference to behavioral and mental health services that are culturally and linguistically appropriate. Also, assessing and addressing gaps and barriers in health services. Data sharing, again, a really important piece of modern public health. And then here's another reference to the healthcare workforce, which is the last bullet, public health's role in contributing to the development of a competent healthcare workforce. As we'll see when we move to essential public health service number 8, which is really about building and supporting a diverse and skilled public health workforce. This essential service number 8 used to have some language about the healthcare workforce, but that's no longer in here. That was moved to number 7 and number 6, as I just highlighted a minute ago. And it's really a very limited role for public health when it comes to the healthcare workforce. But the task force felt that it was really important to have a fairly robust set of bullets here for the public health workforce, which is more neglected and more recognized for being needed and neglected at this moment in time. So they felt that this was a real opportunity to highlight what the public health system needs to be doing around public health workforce. So it includes, providing education and training that encompasses a whole spectrum of public health competencies, including technical, strategic, and leadership skills. ensuring that the public health workforce is the appropriate size to meet the public health's needs. Also, cultural competence, making sure that the public health workforce, including its leadership, reflects the community and practices cultural humility. It talks about incorporating public health principles in non-public health curricula. So a little bit of that health in all policies ideas, but maybe more health in all curricula. More on partnerships, cultivating and building active partnerships with academia and other professional training programs. Promoting a culture of lifelong learning in public health, building that key pipeline of future public health practitioners, and fostering leadership skills at all levels with an eye towards the future. Next slide, please. Essential public health service number 9 is to improve and innovate public health functions through ongoing evaluation, research, and continuous quality improvement. So public health service number 9 used to be evaluation, and then public health service number 10 was research. In order to make room for a new public health service that really recognizes the importance of the underlying organizational capabilities and public health system infrastructure, we combined evaluation, research, and continuous quality improvement along with innovation in this public health service number 9. And the task force really felt strongly that all of those concepts were very intrinsically related and that combining them really didn't lose the importance of any of them. And it really helped kind of illustrate the relationships between all 4 of those concepts. So when you look at the bullets, you'll see, you know, some of the text is about culture of quality. Some of it is about research, linking research with practice, using research evidence and practice-based insights to inform decision-making, contributing to the evidence base, evaluating services, policy, plans, and laws, using engagement and decision-making structures to work with the community. Again, that emphasis on the community at all stages of research. And then the final bullet, valuing and using qualitative, quantitative, and lived experience as data and information to inform decision-making. So finally, we get to essential public health service number 10, which is to build and maintain a strong organizational infrastructure for public health. And the task force had a fair amount of conversation about this one and whether or not it was needed. There were some points made that this is not really a service that is offered to the public, but the overwhelming sentiment was that more important than being parallel to the other services was the emphasis on the need for this infrastructure, because sometimes the way the public health system is funded in a categorical way, you get funding for the public health system to work on this disease or to develop this program, but that essential underlying infrastructure gets neglected. And then when it is time to surge in the time of a public health crisis, that infrastructure isn't there and you cannot build it in an emergency or in the middle of a crisis. And so they felt it was very important to add this language, particularly for use when advocating for funding for the public health system, which is what the 10 essential services is sometimes used to do. So you'll just see some language in here about organizational infrastructure, about leadership, about resources, ethical leadership, decision-making and governance, managing resources effectively, strategic planning capacities, having that robust information technology to be able to do those newer types of data sharing and data collection that were mentioned in earlier services. And finally, being accountable, transparent, and inclusive with all partners and the community in all aspects of practice. Okay, next slide, please. So I'm going to turn back to Jessica to talk a little bit about the Public Health Accreditation Board's domains in the 10 essential public health services.
Katie, I might ask you to go through these quickly and then I'll chime in just a minute.
No problem. So this is just a crosswalk between the 2020 10 Essential Public Health Services, which I just went through with you all, and the FAB domains for version 1.2. So as you can see, the top one is about assessing and monitoring population health status, whereas the FAB domain, which is specifically for the governmental public health system at the state and local level, is about conducting and disseminating assessments focused on population health status and public health issues facing the community. The second one, about investigating and diagnosing and addressing public health problems, has very similar language in the FAB domain 2, investigating health problems and environmental public health hazards to protect the community. Do you want to jump in here, Jessica?
Yes, thank you. Sorry for that. Appreciate everyone's understanding of the challenges of working from home sometimes. So I just want to say, and I see that something came in the chat box, that FAB is committed to using the revised essential services as we're redoing our standards and measures for version 2022. And so that will result in a change that is significant for all things related to version 2022, which is the standards and measures, as well as future reaccreditations. I'll also take a moment to just talk about the alignment with the foundational public health services, another major national initiative. And really everything that's captured in the foundational capabilities, the foundational areas is accounted for here.
I'll pick up here. This is really a document that we just wanted to make sure you were aware it's available. The essential public health services and the foundational public health services are two different frameworks. A lot of times people say, well, why are you updating this one when we have that one? Why would we need both? And it's just important to articulate that they really do serve different purposes, but they're very much aligned. So the foundational public health services was really born out of a need for the public health system to be able to better understand how it spends its resources to get things done, and to also identify a minimum package of foundational public health services that every community should have access to. And so the 10 essential services are essential, and the foundational public health services are foundational, and those may sound like very similar things. But the idea is, with the foundational public health services, there's something there that is very basic that needs to be present in every community. And then above that are additional services that different communities can offer based on community need. But the essential public health services really articulate what it is that the entire field does, and that's governmental and non-governmental. And so they do really serve two different purposes, but this alignment document really shows how they relate to each other, and helps you see that they really don't conflict. They just are two different ways of looking at something that serves two different purposes. Now, I would ask Jessica to, oh, she's changing the slides for me, great. So next steps and resources. I did see a quick question come up in the chat about whether or not these are done. These are done. These replace the 1994 version. You will already find, if you go to the CDC website, this is the version that's on the CDC website. And we are currently reaching out to different publishers of textbooks and trying to make sure that when they come out with their next edition, they put the new version in there. We are hoping that you will share it widely. We also believe this will inform the priorities of the public health system, and we hope it will be helpful in communicating the value and the role of public health. There's a toolkit here at this link that you'll see. It has a lot of resources. It has the alignment documents that we shared. It also has a lot of different images and different sizes that you can use. It has our some of the background information, pretty much everything you would need to use the 10 essential services, communicate about the 10 essential services. There's a PowerPoint deck, both a long version and a short version. So everything you might need is in there. And then I guess there's just one more next step that I want to make sure that I share, which is that we do not plan to let this go another 25 years before looking at it again. We felt like this is a really important process and that we made important changes to the 10 essential public health services, but that doesn't mean that they're perfect for the rest of time or even that they'll last another 25 years. And so it's our intention at the de Beaumont Foundation to convene another expert panel, as we did once before, to really look at the services again and see whether they need to be updated in 5 years. And we want to take a cautious approach because we know a lot of different things are built upon this framework. So we don't want to just change it every 5 minutes. But we also want to make sure that it keeps up with the times and it doesn't leave an idea as important as equity kind of lagging in the field as long as it did this time around. So we will be very happy to take any of your questions.
That's great. Thank you so much, Dr. Sellers. And Jess, thank you so much for, this is really valuable, I think. And I love the active vibe that this new version gives and a much more community engaged sense to these, which is wonderful. There are some questions in the chat box, so I'll go ahead and just put them out to both of you. The first one from Kevin McNally is, do you anticipate that the revisions will result in significant changes to FAB accreditation and reaccreditation standards? And I know you referenced that, but can you talk a little bit more about how significant that might be?
Sure. So it will be significant. We are actively working on what we're referring to as version 2022 now. That's because we intend for it to become available in the year 2022. And that will include initial accreditation standards for those people who are first going through the process, as well as future iterations of those who become reaccredited after that. So we will be looking to revise the number of domains we have to align more closely with this new 10 essential services. So there will be direct implication for those who choose to go through the process in the future. Yes.
Great, thanks, Jess. The next question is from Kakali, and it's in reference to essential service number 10. What should be the role of academia and schools in public health organizational infrastructure, if any? What should be their role in public health organizational infrastructure?
So I think Katie touched on this really well, and I'll get started and invite her to chime in that, the essential services is about the entirety of the governmental public health system. The foundational public health services are about the essential services are about the entirety of the public health system. The foundational public health services are about the governmental system. And then FAB is kind of how you measure that. So I think academia, others absolutely have a big role to play when it comes to the infrastructure. Of course, each agency has their own organizational infrastructure, but collectively as part of that public health system, I think we're all connected. But Katie, I don't know if you have additional thoughts.
Yeah, it's an interesting question because where my brain is immediately going is to workforce and to research and those capabilities in health departments. But that gets us to a place where the essential services are never fully separate from each other. They overlap and they're interrelated. And so I would say that an important part of organizational infrastructure from the governmental public health system, which again, the 10 essential services is about the whole system, but from the perspective of the governmental public health system, having those partnerships with academia are absolutely crucial in terms of pipeline, in terms of learning in the health department, in terms of research partnerships. And also, I think from the academia side, having people from practice available to be teaching, in schools of public health is really important as well. So I think I would think about it in that partnership area most, but I also feel like that's a question that I could give some more thought to and come up with a better answer later because there's a lot there.
Great, and I totally agree with that coming from a School of Public Health. Thank you. One other question is, are there scenarios that can be used to evaluate each essential service for staff development? And I think if, Robert, if there's any clarity you might want to add into the chat box, I think I'm interpreting that as a way of ensuring that public health staff are prepared for and have the competencies to sort of implement that service in their community. And he's agreeing, Robert is saying that that is the term, that's how he's thinking of that question.
So if I'm understanding the question correctly, I think the answer is yes, there could be scenarios that could be developed for that purpose. I don't think we have done that. I do know that the National Public Health Performance Standards Program was designed to do an assessment based on the original 10 essential public health services. Given that that program hasn't been very active lately, I don't know of any plans to develop something like that for the new version. Jessica, I don't know if you have anything to add to that.
No, I think that's right. I wasn't sure if you were thinking about the core competencies of public health, Robert, and asking that question. So that's where my mind went when I initially heard it or saw it in the chat box. And we are planning to do a crosswalk between them. There is an existing crosswalk from the 1994 version of the EPHS and the last version of the core competencies, which were developed, I believe, in 2014. But no, I don't think we have plans to do anything beyond that.
Okay, thank you. We do have a couple of more questions, and if you're okay to take just a couple more. I think a very important question, and Leslie, I'm going to ask you to can add more to your question here, just to be sure I'm understanding it, or if you have suggestions. But the question that Leslie raised is, do you think there's other words that can be used to define multicultural and ethnic differences other than just the term of race? And I think there's some connotations there that there might be something negative when we're using that term, and it might create some division that isn't the intention. Leslie, I'll ask you to add into the chat box if there's anything different that you meant from that.
While we're waiting for any additions to that question, I'll just say that we selected the task force with equity very much in mind, and made sure that we picked some real leaders in the field who are leaders in promoting equity, and really deferred to their collective judgment about how language really on all things related to equity ought to be phrased in the new version. And so I wouldn't claim to be an expert on what language should or should not be used there, but I think we had some very thoughtful people who didn't have too much trouble coming to consensus on what language they thought was best for promoting equity and undoing harm from past practices.
Okay, great. Thank you very much, Katie. I'll just give one more second if there's any other questions. I don't think I see any others. Let me just double check. No, I think we've covered them all. Great. Well, I thank you both very much for your participation, and this was excellent and very valuable. I think these look really fantastic, and look forward to seeing them sort of align more closely with FAB standards and the core competencies. I'm glad Jessica mentioned that as well. After this program, I'll be sending out to all of you the evaluation for today's webinar. And thank you so much for joining us. And we certainly wish all of you enjoyable holidays, and let's look to a healthier new year for everybody. So thank you, Katie and Jessica, so much.
Thank you all.
Have a great day. Bye-bye.
Bye-bye.
Thank you.